Hello, everybody. It's March 27th. Welcome to our rounds for this month. We have the honor of highlighting our new PFT lab, which I'm so excited about. Today we have Dr. Karen Mills joining us, who's just come on screen. She joined West Parry Sound Health Center in 2010 as the staff general internist and is the current department chief. She is the new medical director of the West Parry Sound Pulmonary Function Lab. We also have Stephanie Foucher. She joined us in 2023 as a clinical manager for the outpatient rehab, respiratory therapy, and diabetes education program. She has 15 years as a registered RT and has been predominantly with the Pulmonary Diagnostics, sorry, I can't speak, and has been in leadership roles within Alberta Health Services in Calgary for 8 years before joining us here. We also have Ben Jones, who joined us in 2021. He has worked as a frontline registered respiratory therapist since graduating and has a passion for respiratory education and pulmonary diagnostics. He has taken the COPD respiratory educator course and spirometry courses, advancing his experience and expertise. Welcome. And when you're ready, I'll let you guys take over.
That's great. Thank you so much for those introductions, Kathy. And yes, we are very excited to be speaking about our pulmonary function lab that is now open and operational. It's been quite the journey over the last 3 years. And so we're happy to talk a little bit about that and talk a little bit more about pulmonary diagnostics and have some case studies. In terms of speaker disclosures, no major disclosures other than Dr. Karen Mills for getting the compensation for doing the interpretation fees for our pulmonary function reports. Ben and I have no disclosures to speak of for this. So as I shared, our learning objectives today, we're going to just quickly describe our implementation and referral process here for West Parry Sound Health Center. Really explain the importance of screening, the quality testing that we do here using ATS standards. We're going to go into explaining a little bit about that burden of COPD in healthcare, and then do a couple case study reviews to close it all off. So essentially our pulmonary function lab implementation, there was lots of phases over the past 3 years that we really worked towards. So there was a lot of preparation going on, lots to do with equipment. As we know, for the pulmonary diagnostic equipment, it's very specialized hardware that communicates with software. We had to actually develop it, which meant, being able to recruit for staff and get that training up and ready. And then the standardization piece, that's really important for our quality management systems and controls that we put in place. And then working towards our completion and final preparations to get the lab up and running. So essentially just, to start with, the year of 2022 to 2023 was really high on our preparation. So really starting to build that understanding and get some background information ready so then we can act to implement our PF lab. So there were some tours of other facilities that went on, really looking at potential spaces here at the West Parry Sound Health Center, really making sure, that it meets our CSA standards for, being able to perform these breathing tests. So looking at air exchanges, does it have a hand washing sink? Is it safe? Do we have call bells? So really just looking at that environmental space. Looking at it, researching our local health regulations and funding options. So we were very thankful, and I'll talk about on the next slide about the fundraiser campaign that we are able to do to help to be able to get this pulmonary function lab from preparation and into a build phase. And then we looked for the regulations, looking at the CPSO, Accreditation Canada, and ATS standards to really make sure that our lab meets those. Business plan was created and approved by our senior leadership, and then a project charter was created, and we started the collaboration and engagement amongst all the different stakeholders. So this is really want to take a moment to thank our incredible community and their generous donations and fundraising efforts, which really made the Pulmonary Function Lab possible. And so back in the spring, summer of 2022, there was the walk, run, poll that was able to fund the majority of our Pulmonary Function Lab here at West Parry Sound Health Center. So it was really, we're very appreciative of that. So thank you very much. Next coming up was equipment implementation. This took, 6 months or so to get the equipment here on site. We actually have been in the background. You can actually see our Pulmonary Function Lab and all of the equipment pieces there. But we were able to secure a body box and procure that on site, order all the necessary equipment. And the real big piece was the IT infrastructure, and that takes probably the longest piece. So there's all of the parts for booking, orders, billing, all through our Meditech software and electronic health record. And then we have the software that communicates with the hardware equipment Ascent. So making sure that that's installed and then is actually able to be put on our VDI, so there can be remote options to view all of the reports and be able to get those interpretations done. So there was a lot of work that was going on in the background during the equipment implementation. From there, it's all just about development. So recruitment and training. Recruitment has been a real challenge. It took us 8 months to be able to recruit for a respiratory therapist to join our team alongside Ben to support our pulmonary diagnostics. And then from there, it's just making sure we do all of the training, get the courses ready, collaborate with other of our partner pulmonary function labs, and make sure that we practice and have the competency requirements before we launch our facility. And then the training that goes alongside with the software for Meditech and Ascent, and that goes across all of our teams. And then going into standardization, this phase was really large as well, just making sure that our testing facility and all of our quality management systems are up and started. So again, just looking at, our qualified staff, making sure that we have a compliance with those standards that are set forth. Equipment calibrations and maintenance. It was really important to have all of the equipment checklists and logs. The great thing about our software that we have here is it houses and creates a lot of that already for us. So when we're going through and doing our biological norms and our daily calibration checks, it'll actually capture the trends. So then we can see if something's going on with our equipment or if there's something else that we need to reach out to our vendor to make sure that our equipment is functioning. This just kind of highlights the importance of following ATS standards. It is evidence-based guidelines, really ensures that accuracy and reliability and consistency in testing methods. We ensure patient safety and reproducible results across different labs and healthcare settings. And the core elements of those ATS standards is really making sure we have that proper test equipment, the test procedures, those quality control measures, and data reporting. And so essentially we were able to, over the fall and now coming into, now we're coming into spring, hopefully, once the snow finally wants to let go. But our final preparations were completed. We worked out some workflow processes, started our soft launch in November, and we were going really slow, just ironing out all of those workflow processes with the referral to the booking, interpretation, and billing. And now we're officially launched and fully operational Monday to Friday, 8 to 4, as long as staffing allows for it. And we can complete about 6 to 7 complete pulmonary function tests daily. We're always continuing to look to see where we can improve for efficiencies, but that's pretty much the amount that we'll be able to do. And I'm going to pass it over to Ben now to talk a little bit more in detail about our referral process and the importance of testing.
Thanks, Stephanie. So thanks everyone for this opportunity. You can see on this slide here lot of text, but highlighting our indications and contraindications. And that's really core to having the beginning of a good quality PFT. So indications, why are we doing the testing? Our facility, we're primarily focused on the two main headers, diagnostic and monitoring. So if there is a presence of a disease, and then are we monitoring that disease after, or their effectiveness of their therapeutic intervention. And really, I'll let Karen speak to when the testing should be done with our case studies at the end of this presentation. But really, those are our two main reasons for doing PFTs. What I want to focus our attention on, though, is the list of contraindications. So contraindications are here for two reasons. One, is it safe for the patient to have the PFT? And two, are we testing what we're intending to test? So when I say intending what we're intending to test, if somebody, let's say, has acute pulmonary edema and they get a PFT, that could potentially show that they have some sort of restrictive lung disease, when in fact they don't have a restrictive lung disease. So we're screening for that to make sure that the testing is accurate and we're getting information where we can make sound clinical decisions later down the line with the results. We screen for it in 3 separate places. So we're really thorough, making sure we're not leaving any stone unturned, so to speak. So the first place you'll see when we get to the next slide is on our referral form. So we have the list of the contraindications there. What would be really helpful when you go to do a referral is if you know there's a contraindication, say a presence of an aneurysm that's being monitored and tracked, identifying that on the referral form so that it streamlines the process. Yes, you're aware, we know it's safe to do the test, and away we go. The second point of contact for screening contraindications is when our booking clerks call the patient to book the appointment. And this is really important for getting, because it's possible, it could be a month or 2 from when the referral was sent in to when we are booking them. This is just utilizing our booking spaces more appropriately. So we're not booking people in, they're showing up, unable to do the test. Now we're just wasting that time, that testing time. And then our third screening is when the patient actually shows up to the test, because again, that could be 6, 8, 10 weeks from when appointment was made, just making sure that there was no changes in that time so that the patient is safe to do the test and it's appropriate to do that testing. If you want to do the next slide there, Stephanie. So here is our referral form. The memo was sent out November 19th last fall. So I believe all the clinics in our area have that report. If you don't, then I'm sorry that we missed you, but you can contact us and I can get you that referral form, no problem. Just the main things: complete the form thoroughly. If uncompleted forms, we will send back. And then again, looking at that bottom left corner, the contraindications, again, if you see any of those contraindications that are present, but you're okay with the testing to proceed, please highlight that on the referral form, because if it's found out that the patient has it and there was no note made of it on the referral, you can expect a letter back from us just to be like, hey, we noticed this. Are you still okay with them having the testing done? Let's say it's a time-dependent contraindication, such as surgery, then we just delay the booking until that time has elapsed and it's safe to continue testing. You'll also note under section 3 there in the middle of the page, special procedures. So previously our home oxygen clinic had a different referral form. That one is still valid. But you can also use this form if you're looking for patients to get assessments for home oxygen. We also offer some other specialty tests, so like a 6-minute walk test for exertional tolerance. And then we also can just do arterial blood gases independently of the home oxygen. So let's say a respirologist is asking for that, we can definitely do that here. And then checking off risk factors in the bottom right there, that just gives us an idea of what we can expect should something go wrong, what kind of assessment we need to do should a patient deteriorate, or what kind of adjustments do we need to make sure the patient is aware of. So using smoking as an example, that can skew the results of our diffusion testing because of the presence of carbon monoxide in a cigarette. So just making sure that we're able to tailor the test so it's accurate to the patient. So we go to the next slide here.
Yeah, before we go to the next slide, Ben, I just wanted to also highlight, we are getting very close to our new website, getting up and running. Once that's functional this spring, so it should be, I believe it's in May, our referral form will be accessible through our West Parry Sound website as well. So if you're needing to get access to the referral form, you can go through the website as well.
That'll be so handy. Amazing. So the next 3 slides, I will not bore you with the technical details. That's mine and Glenn's and Stephanie's job to know that the tests we're doing are accurate and precise with the acceptability and repeatability criteria as outlined by the ATS standards. But really what you need to know is that every test we do have a very stringent set of criteria to make sure that it's accurate and precise and repeatable. So if you have a test done here, or patient has a test done elsewhere, such as Mount Sinai or HSN or wherever they've had a test before, you know that you can compare those tests reliably and accurately and make good sound clinical decisions. So for spirometry, this is our textbook bread and butter diagnosis tool for COPD. We'll let Dr. Mills elaborate that on the end. We also offer, if we go to the next slide, this is our diffusion testing. So we're exposing patients with a single breath test that has trace amounts of methane and carbon monoxide, again assessing if there's any diffusion impairment. And then if we go to the last one, do not be fooled, the plethysmography is a tricky one. Even though it looks like there's not a lot of criteria here, I'd argue it's the hardest one to get meet the criteria for. And why, you might ask, if we go to the next one, all of these tests, unlike, diagnostic imaging or lab work, blood work, these are all effort dependent tests. So if a patient is unable to give a maximal effort and coordinate at specific times to breathe in very, to be frank, odd ways, then we don't get good quality test results. And that's where the importance of having a qualified technologist who's a good coach, who's able to get the best performance out of that patient. I mean, it's kind of ironic that we take patients who are dealing with chronic disease and have difficulty breathing on a daily basis, and we're asking them to do maximal effort breathing tests. You really have to be that hype man, making sure that you're getting that good performance out of the patient so we can get the test results we need, so we can make the proper clinical decisions from that. And really this quote here, this comes right out of the ATS standards manual. 3 things for a test. So you need, good equipment. We have that. We need the patients who can do the testing. That comes from you guys. And then we need the technologist who can elicit the best possible performance, which is Glenn and myself. So we have all the things we need for success. Now it's just we're getting the ball rolling. So from here, I believe it's Dr. Mills' time to take the stage.
Okay, so I thought we could do a couple of cases just to kind of illustrate what clinical issues would lead you to order what test. Just before we jump into that, in terms of the COPD burden on the healthcare system, it's clearly substantial. I think any of us who work in primary care or in hospital-based work have seen these patients coming in. And when I looked it up to see, I know it's reliably in the top 10 list of admissions, but when I looked it up, this reference actually said it's number 2 behind labor and delivery for reasons to be admitted to an acute care hospital. And so in Canada, COPD affects 10% of the adult population, but it's wildly underdiagnosed. So for example, it's not rare to have people referred for stress testing and then to note that they desat on the treadmill, and then you do their spirometry and lo and behold, they have, moderate COPD. So it's often underdiagnosed. And so, getting that diagnosis and communicating it and having results that are accessible to clinicians is important. So let's go to the next slide. Okay, so this is a case. So this is a lady who was 74 and she was referred to me by her family physician, not because she had any internal medicine concerns, but because she wanted elective surgery. So she had spinal stenosis at C3, C4 with radiculopathy. And so she was referred to a neurosurgeon who was fairly astute and felt that her breathing was possibly an issue. And so she told him she had asthma. And so he had suggested that she see a respirologist to be cleared for surgery. And as you know, it's difficult to get respirology referrals in a timely fashion. And so her family doctor had sent her to me to find out if I could take care of this. So she had a complicated history. She actually had coronary disease with a cardiac event in 2002 that was just non-invasively managed. And then all of the comorbidities you see there, the one that's sort of relevant is she had this remote Guillain-Barré syndrome in the 1960s. But she had like lots of comorbidities. So next slide. So the medications that she was on, the relevant ones for today are she was on triple therapy for her lungs. So she's on CB Breezhaler as her long-acting muscarinic agent, and then she had a combined ICS LABA in the form of Symbicort, and she was also actually a frequent exacerbator and was on daily azithromycin at baseline, and then a variety of other medications for her other comorbidities. Next slide. So as usual, when people want an elective surgery, they kind of tend to minimize their symptoms. But it was pretty clear that she had NYHA class 3 dyspnea, and she had multiple admissions for exacerbations, like at least 3 a year. There were no sputum cultures available. She every appointment endorsed wanting to quit, but then I would, do all this smoking cessation counseling and write prescriptions, and she would never fill them. And so when questioned about, what the resistance was to using nicotine replacement agents, she actually endorsed the idea that she had gotten Guillain-Barré syndrome and recovered, and she felt that smoking somehow made her recover and that she would relapse if she quit smoking, which of course is not true. It's an acute demyelinating problem and everyone recovers. So, and then she tried to tell me she had to smoke because that was what allowed her to cough up phlegm. The reality is she had a very terrible nicotine addiction and was living in sort of communal housing with other smokers, which obviously makes it more challenging to quit. Okay, next slide. None of this is super relevant other than she had been smoking for 60 years, was still actively smoking, looked quite chronically ill, hence the neurosurgeon picking up on the lung disease, and did have a murmur of TR, which is relevant because she did go on to develop core pulmonality. Next slide. So this is her office spirometry. I was saying to Ben, it's sort of a bad sign that there's only 2 trials done, like she literally couldn't do the 3rd trial. But if you look, so this was my old school, like basic office spirometry. So her FEV1 is less than half a liter, 0.43 liters, which is pretty terrible, 22% predicted. And then her FVC was less than a liter, or at 32% predicted. And then there was no response to bronchodilators. So when you look at her flow volume loop curve, you can see it's like horrible obstruction to airflow with that scooping, in keeping with, with very severe COPD. And actually her small airways, her FEF 25 to 75 is like 10% predicted. So horrible smoking related obstructive lung disease. So you get a lot of information from basic spirometry for these patients. So needless to say, not cleared for elective surgery with a general. Next slide. So we can contrast that case with this case. So also an elderly lady referred for chronic cough and dyspnea. Nothing super relevant in her past history. And medication wise, she was treated for her hypertensive heart disease and her psoriasis and whatnot, but she wasn't on any pulmonary medications. Next slide. So her story is that she went on a cruise, and when she was on the cruise, she was complaining of dyspnea and cough, and she had some fever. She was given antibiotics by the ship doctor, and then the cough didn't really go away. And then despite that, she went to Florida for 3 months, but when she got back, she was getting worsening dyspnea. And so she saw her family physician. She had an x-ray done that suggested she was in pulmonary edema. So she was given, started out with low dose Lasix, and they actually titrated her up to furosemide 80. But it did absolutely nothing to improve her symptoms, and all it did was give her gout. And then the relevant history is that she hadn't been on any drugs that cause pulmonary toxicity like amiodarone or nitrofurantoin or anything like that. Next slide. She was a lifetime non-smoker, which is relevant when you're talking about shortness of breath, retired teacher. And on her examination, the relevant findings were like her stats were borderline low, 94%. And she had these horrible Velcro crackles over her inferior posterior lung zones. And so her first x-ray, the radiologist reported as pulmonary edema. The second x-ray, they reported it as subpleural pulmonary fibrosis. She had an echo done, her ejection fraction was preserved, and she had normal pulmonary pressures. Next slide, please. So this was her initial spirometry. So you can see the difference in the shape of the flow volume loop curve. So she does not have scooping. Her FEV1 was 1.78 liters or 103% predicted, so normal. And then her FVC was just lower, sort of, I think of 80% as normal, so just kind of low-ish. And then there was no response to bronchodilators. So that's in contrast to the other lady. So is there a next slide? I don't think so. No. So then what happened with this lady was I told her, just based on her imaging and her office spirometry and her physical examination, that unfortunately I thought she had pulmonary fibrosis, and referred her to a respirologist and for full PFTs to support that referral. She probably went home and Googled idiopathic pulmonary fibrosis, wasn't very happy about it, and was impatient. And so she ended up seeing a respirologist in the States for private pay, and they did full PFTs there. And the full PFTs showed, actually they reported normal lung volumes, and then she had a diffusion an isolated decrease in her diffusion coefficient in keeping with early IPF. And so the respirologist from the States concurred that she had early IPF, but felt that no treatment was indicated. She went on to see respirology in Toronto and was eventually put on antifibrotic therapy. And she's actually still with us and has done reasonably well. The other lady didn't do so well, kept smoking, kept coming in with exacerbations, was put on home oxygen, developed cor pulmonale, and actually died earlier this year. So definitely the money for the first lady was in the simple office spirometry. It's cheap, it's fast, it tells you what you want to know. It doesn't tell you whether the patient has an emphysema phenotype or a chronic bronchitis phenotype, but that's usually pretty apparent clinically. So that lady had a chronic bronchitis phenotype. For the restrictive, or I guess you should call it non-obstructive decrease in lung volume type scenario, the full PFTs are really where the money is, because on this lady's test, if her FVC is slightly low, it doesn't tell you whether it's a lung problem or an extra parenchymal problem. And so, we have lots of patients who are obese, who could have scoliosis or other reasons, chest wall reasons to have restriction. And so it's useful to get the full PFTs so that you can get more volume measurements and also check the diffusion capacity, because that was useful in formalizing her diagnosis. Okay, so next slide. So I guess we'll turn it over to Stephanie.
Yeah, for sure. So in conclusion, essentially, we just really wanted to share and highlight, how essential pulmonary function testing can be for diagnosing and managing respiratory diseases, highlighting really that burden to the healthcare system with COPD. Really how important it is to follow those appropriate standards and guidelines to get those accurate standardized tests, because a lot of what we do is trending to look at that monitoring piece, right? So one of those indications for PFTs. And again, just we really want to express that deep gratitude to our community for supporting the new Pulmonary Function Lab, which will continue to improve our capacity to serve and enhance the health of our patients. So really want to thank them and everyone, because this work really was a collaborative team effort. And not sure if there's anything, Dr. Mills or Ben, you want to conclude with.
If anyone has any questions, like either clinical questions or technical questions.
Thanks, everybody. Can I ask a question about just like referrals and who you might or might not accept referrals from? With the there's an age question on the referral form, and it says like, are they above 18 years old, years of age, yes or no? What is the minimum age that you're willing to do PFTs for?
Great question. In terms of our facility, we agreed upon adults for pulmonary function tests. In terms of any of the ones under the age of 18, I believe the place to send them is down into Aurelia, but I'll just let Dr. Mills comment any further if there's any nuances to that and what that might look like.
Yeah, so I can't speak to, you know, if the program here is decided on 18, then that's fine. Definitely in my clinic, this comes up a lot with Holter monitors as well. I'm definitely comfortable. You know, we've done office spirometry for the community before this program was in place, and we've definitely done, you know, spirometry on 10-year-olds and 14-year-olds, and it's fine. You know, we don't have any training to deal with like small children. And obviously the nuances of interpretation could be different as well. So the people reading the test locally are Dr. Jakubowski and myself, and we are definitely not pediatricians. So the beauty of doing it in a center that has pediatric support is you get either respirologists that have done some pediatric training or pediatricians involved in the interpretation, which I think is probably a good idea. So I think they just, for ease of getting the program started, settled on 18. We could probably be open to discussing that, you know, as the program sort of gets established and evolves, but for now it's 18. But if you need somebody done in the office, I'm sure Fran will do it. If they're big-ish, it's kind of the same as, you know, what snake bites do we keep in the hospital, or if kids have, you know, pneumonia or something, you know, we'll often keep a 12-year-old, whereas the 4-year-old would go out. So it's sort of a gray zone, but formally 18, if you've got a big person sized, you know, teenager and you want them done, just ask me and we'll make it happen.
Great, thank you.
And just further to that, for my job, I'm just wondering, are you accepting referrals for PFTs from outside the Parry Sound area? So I'm thinking my thoracic surgeons and respirologists that I work with.
It's a great question, Kathy. In terms of right now with, you know, our catchment area and building our business, we do have it open, but if we start to reevaluate and our wait list for our community is increasing, then we might have to change those parameters. But as it stands right now, yes. Okay,
perfect. And I was meaning patients within Parry Sound, but their specialist is outside.
Yes, correct. Yeah.
Okay.
Yeah, with that, Kathy, it's you know, some of the patients that have already come through, they've really highlighted the value of that because they can get their pulmonary function test done here and then actually do their OTN or virtual appointment with their respirologist, and that saves them from driving down to Toronto or Barrie And as we know, with people with, pulmonary diseases, traveling with a whole bunch of oxygen, trying to find parking in Toronto, and then go do a full PFT, see the physician and then respirologist, and then come all the way back here. It really is very taxing on them and can actually cause more harm than good. So this is a great addition for our community here.
Questions?
I actually had, it's John. I had a question just on the referral form. I see there's like PFTs pre and post as well as just pre. What sort of candidate would it be that I would be wanting to do just the pre? 'Cause it seems like at least in the olden days before the PFT lab, all of them seemed to get pre and post, and I just wasn't sure, is there is there a certain type of candidate of patient I would be referring that would just want the pre test?
So clinically, when I've just done pre, it's been either because the person really doesn't tolerate bronchodilators. So they endorse that, Ventolin or salbutamol makes them extremely jittery and they basically refuse to have it administered. Then obviously you're not going to do pre and post if they refuse the medication. And then you could make an argument, that if there's no obstruction to airflow, seeing if the obstruction responds to bronchodilators is kind of irrelevant, right? So you could make an argument that if the spirometry free is totally normal, do you need to administer bronchodilators? But of course you don't know that when you're ordering the test. So that's kind of another thing. And then the other situation I've just encountered is that people can't, they get too tired and they can't perform all the trials. Like the lady in my case couldn't do all the trials. And then, or I've had people actually have syncope from, when you're asking people to breathe all of the air out of their lungs with this sort of forced expiratory maneuver, then their venous return decreases and their blood pressure drops. And so when someone's eyes roll back in their head in the middle of your clinic, you're not excited to do more trials. So I've actually just omitted the post because I don't want to be calling a code blue in my clinic. I don't know, do you guys have any other?
Yeah, in terms of some of the referrals from respirologists, if they're post lung transplant, they'll only be looking for that pre-spirometry, really for trending and to see, if they're triggering to, go into to have a bronchoscopy and kind of look at that toileting that can go on with that after a post lung transplant. So we've seen that a little bit with the respirologists where they would want to just complete that for post lung transplant. That's kind of the other one that I can think of.
Great, thank you so much. And again, congratulations and well done, team, on setting this up. I think it's great for our community and really exciting to have. And I know there's a lot of hard work put in behind the scenes, and it's great to see it finally go live. So thank you.
Awesome, thank you.
Any other questions? Okay, I'm not seeing.
I do
go-
want to highlight before maybe this gets finished, that if patients who have PFTs, so you're part of the communication of information and the reports at the end, is all those reports are going to get scanned into Meditech, now EHR. So should they ever become emergency or admitted inpatients, the ease of access for getting those reports and getting that information is going to be a lot easier than what we currently are dealing with, the hit or miss reports on Connecting Ontario. So that's good. I personally think that's going to be a huge, and just having an idea of what we're dealing with our COPD and other lung disease patients.
Yeah, I agree. So we have patients in our community that have had office spirometry. And it's all buried in some PFT only archived, chart in an internist's office. So, Yeah, lots of people, and conversely, there are people that are being admitted with COPD exacerbations who've had spirometry showing normal lung function. So, you know, information is power, and being able to actually see the results is key. And so there was a cost involved in being able to upload the results to Meditech, but we think it's really important that everyone can see the results and have that information when looking at patients presenting to our health center. So that's like one of the major reasons to get the testing done through the hospital, is just so that the results are available for future use. And now, like if you send a patient to LDAP, for example, for a pulmonary nodule or a mass, they're going to want to know when planning, you know, surgery versus radiation, they're going to want to know what that patient's lung function is like. And now that they're live on Meditech, they'll be able to see those results. So very helpful.
Ben, did you want to show the PFT?
I could show it. Yeah, we can. So this space, we're located, if you're wondering where we're located, on the first floor in the hospital in the outpatient rehab facility. So I'm going to try and zoom in on with the camera here and move it over. So this is our body box that Stephanie was going into detail about. So in this body box here, let me know if you can't hear me. I'm going to sit in the box, but our patients get to sit here. And it's actually a really well-designed box. We can get, I don't think there's a weight limit on it. Right, me, Stephanie? Yeah, there's no weight limit. So as long as the patient fits, we could do the testing. And so it's really quite a comfortable and secure box. And, you know, I've worked with a few designs of PFT equipment, and so has Stephanie. And this one, like claustrophobia is a big piece, especially when we have to do our lung volumes and we're like, we close the door, we seal them in. I like to call it like the little rocket ship, but because it's all a big wall of glass, patients actually have been feeling really comfortable. So that's been really incredibly helpful. And it's also great too, being on the first floor here, because again, we're dealing with patients who are chronically short of breath. Because we're not having to go up or down stairs or hills, the patients actually come less exhausted to do the testing. So that's been a really great boon. As well, our space really well, nice and bright. It's a little fun tidbit here is we asked patients in our pulmonary rehab program to select the color that we were going to paint the space, and we gave them a variety of options, and they chose this one, which, believe it or not, this color of blue is specifically called smoky blue. Smoky blue.
Yeah, I think it was smoke. Yeah, smoke
blue, which I think is a bit ironic. So this is the lab. This is where all the testing is going to be happening. So if you're ever wondering where we're doing it, it's down here. And no, it's not portable. It's not portable.
No, not portable. The one other thing too is it is partially accessible. So if we have wheelchair bound patients, we can perform the flow volume loop, spirometry, and the DLCO. We just aren't able to complete the lung volumes. So we just don't have that capacity for the last test, but we are able to complete it with them sitting in their wheelchair outside of the body box and offer that as well. So.
Okay, thank you.
Yeah.
Any other questions, comments? Not seeing anyone unmuting. Okay, well, thank you very much to everybody. That was wonderful, and I'm so excited that we finally have this in our community, and I know patients are excited from what I'm hearing, and I'm sure you're hearing the same, and yeah. So our next virtual rounds are April 24th, and it's with Dr. Vivian Brown, who will be speaking on women's health. So make sure to look for the poster. It'll be coming out shortly, and sign up. Otherwise, that's it. Have a great day, everybody.
Thank you.
Thank you.